Across the borders of the Democratic Republic of Congo and Uganda, a localized health crisis is breaking containment. Between May 5th and 15th, 2026, centers recorded over 80 fatalities and 246 suspected infections, with 8 index cases confirmed by PCR. The World Health Organization reviewed the data and concluded that the outbreak could no longer be contained by regional resources alone. This triggered an Article 12 declaration, a public health emergency of international concern, representing the highest level of global health alert. The pathogen driving this emergency is a highly dangerous variant of a viral family health officials have tracked for decades. This specific variant is known as the Bundibugyo strain of the Ebola virus. Understanding the severity of this alert requires us to deconstruct the virus's mechanics, from its microscopic architecture to its impact on global human networks. The Ebola virus first emerged in the medical record in 1976, originating in the dense forests near the Ebola River in Central Africa. This is the physical structure of the virus under an electron microscope. Its core identity is a single-stranded RNA core within a filamentous envelope. RNA viruses lack cellular proofreading, causing a high mutation rate, where every replication introduces errors. These cumulative mutations produce new structural variants, like the Bundibugyo strain spreading today. These structural shifts can make older countermeasures obsolete. Consequently, there is currently no approved vaccine specifically calibrated for the Bundibugyo variant. This RNA architecture forces medical science into a constant race against a pathogen that evolves as it spreads. The virus survives between human outbreaks by circulating in a natural biological reservoir in the wild. The primary reservoir for the Ebola virus is the fruit bat, or flying fox. The virus sheds from these bats into the forest environment, contaminating food sources and the forest floor. Large mammals like chimpanzees and forest antelope become infected when they forage in these contaminated areas. Local populations live in close proximity to these infected ecological zones. When humans hunt and process these wild animals for meat, the virus crosses the species barrier, resulting in a human index case. These index cases are the direct result of human survival practices intersecting with high-risk forest ecosystems. Once the virus establishes itself in a human host, it triggers severe fever, extreme fatigue, and gastrointestinal failure. The disease then progresses into its advanced phase, Ebola hemorrhagic fever. During this phase, patients experience internal bleeding and spontaneous external hemorrhage as the virus attacks the vascular system. Unlike airborne pathogens, Ebola cannot spread through the air. It requires direct contact between hosts. Infection occurs through contact with saliva, blood, tears, or surfaces contaminated by these fluids. Healthcare workers are particularly vulnerable, as they must operate in constant proximity to symptomatic patients. A secondary risk factor is found in traditional cultural practices surrounding death. When family members physically handle the infectious bodies of deceased loved ones during burial, it often triggers a cluster of new infections within the community. The virus exploits fundamental human behaviors, caregiving and mourning, to ensure its own survival. The virus benefits from a biological blind spot, an incubation period that ranges from 2 to 21 days. During this window, the host remains asymptomatic while the virus replicates internally. This slow, hidden biological timeline stands in stark, dangerous contrast with the blistering speed of modern international air travel. If we overlay this 21-day window onto flight paths leaving Central African hubs, the global risk becomes apparent. An asymptomatic carrier can board a flight, cross international borders, and arrive at their destination well before symptoms ever appear. Breaking this chain requires strict adherence to clinical isolation and hygiene protocols at the site of the outbreak. Frontline responders must follow rigorous decontamination procedures for their protective gear to prevent the virus from escaping the clinic. The 21-day incubation period allows a localized fever to become a mobile international threat. This risk of rapid transit is why the WHO issued the Article 12 declaration for the Bundibugyo outbreak. Without an approved vaccine for this strain, health officials cannot rely on pharmaceutical interventions to stop the immediate spread. Instead, the primary defense is rapid data sharing. Real-time reports from isolated clinics are synchronized across international health agencies. This coordination enables contact tracing, allowing officials to track the path of the virus across international borders. The goal is to identify and isolate every individual exposed to an index case before their 21-day incubation window closes. This data-driven containment strategy is currently the only effective method to disrupt the transmission chain between humans. Against an evolving RNA virus, our most effective defense is unified global epidemiological intelligence.